Thanks very much. I'm going to tell you a little bit about how to think about treating your newly diagnosed patient who could be eligible for stem cell transplant based on some of the available regimens, mostly with a focus on some of the drugs available in the US, but as I mentioned earlier, many of these are now becoming available more generally. These are actually the updated NCCN guidelines for transplant-eligible patients with myeloma. And the interesting thing is that even though we have more drugs now available, the number of options has actually decreased a little bit, if you remember from the past, because you'll see that the preferred regimens now are just 3: bortezomib with cyclophosphamide and dexamethasone, or bortezomib with doxorubicin and dex, or bortezomib with lenalidomide and dex. And some of the category 1 recommendations have actually been moved down to less preferred or other regimens, including things like bortezomib with thalidomide and dexamethasone, and the 2-drug combos, bortez and dex and len and dex. So I thought I would just go through some of the data that really support the various recommendations. There have been lots of studies looking at CyBorD in myeloma, and I didn't want to go through all of them, but this is just one which showed that it has a very good response rate, usually 75 to 90% of patients. And it does have the advantage that in most places cyclophosphamide is relatively cheap and therefore easier to give than perhaps more expensive drugs like lenalidomide and thalidomide. The interesting thing about it still being preferred is that there was an abstract not at 2016 but at 2015 ASH where the French compared CyBorD to bortezomib, thalidomide, and dexamethasone. And what they found is that after 4 cycles, this is not until progression, after just 4 cycles, that the bortezomib, thalidomide, and dexamethasone had a better overall response rate and also a better VGPR rate or better. And so in some ways, if you're only going to do 4 cycles of therapy, it may be that CyBorD is not your best choice. And the adverse events were what you would expect, a little bit more cytopenias with the cyclophosphamide, but more GI and neuropathy events with thalidomide. One of the options as category 1 and preferred is bortezomib with doxorubicin and dex, and I'm sure you remember the Dutch and German trial which showed that if you gave bortezomib with doxorubicin and dex, then transplant, and then bortezomib maintenance, you had a better overall outcome, especially if you had a deletion of 17p, which a little bit answers some of the questions that Dr. Lin asked earlier about that subgroup. The most recent data, this paper was actually just published within the past few weeks, which was the SWOG study that compared lenalidomide and dex versus bortezomib, lenalidomide, and dex, both given for 8 cycles. And then on both arms, patients went on to get lenalidomide and dex as a maintenance. And you probably know the data showing that VRD had a better progression-free survival. And this was both in transplant-eligible as well as transplant-ineligible patients. And interestingly, the survival data were better as well, which is a little bit surprising considering that they only got maximally 8 cycles of a bortezomib-containing therapy before going on to len and dex. And if you look at the response rate and quality, you'll see that the overall response rate was better if you got the 8 cycles of bortezomib-containing therapy, and there was also a trend towards a better, very good partial remission. Other combos that are up there, bortezomib and dex. This is just one of the studies that compared, for example, VD to the old standard VAD and found that it was at least as good, if not better. And then bortezomib, thalidomide, and dexamethasone, which again has been studied by many groups, including the Italians, who showed a better event-free and progression-free survival, which was maintained after transplant, which tells you that the better your upfront therapy is before transplant, the better will be the outcome after transplant. Lenalidomide and dex was down there as one of the other regimens, and again, a number of studies, but this one from ECOG was very instructive because it compared len with high-dose dex to len with low-dose dex and showed that the low-dose dex regimen was at least as good and maybe a little bit better in terms of survival. And that was exciting because usually in oncology, we think that if a little bit is good, more has to be better. And in fact, here the opposite was true. You could do just as well or better with less therapy, in this case with less dexamethasone. One new combination that made it onto the list is actually ixazomib with lenalidomide and dexamethasone. This is interesting because although you know that IRD is approved in the relapsed setting in the US, it hasn't yet been approved for newly diagnosed patients. But because of this phase 1/2 study with an all-oral regimen, which showed that there was a good overall response rate, and you can see that about 27% of patients had a complete remission after 12 cycles with a very well-tolerated oral regimen. This was in part what led to that being listed as an option. And you can see from this waterfall plot that quite a few patients had a 100% reduction, and many more had a 90% or more and a 50% or more induction benefit. And of course, although ixazomib is a new drug and will probably be a little bit expensive to start with, the flip side is that because it's oral, it could ultimately be cheaper because you don't have to administer the drug intravenously or subcutaneously. You don't have to get the pharmacy involved. You don't have to get the nurses involved. You don't have to bring the patient to your clinic. And so ultimately, from a cost-benefit perspective, this may be something to look at. Now, carfilzomib with len and dexamethasone was included in that, and this is based initially on Andrzej Jakubowiak's work, where they were able to show that there was quite a nice, almost 100% response rate with this combination, and a high rate of stringent complete remission, suggesting that maybe KRD could be better than VRD. And this is being tested now in the US by a cooperative group study, which is comparing VRD to KRD head-to-head. And I think that probably KRD will be better, although you may remember that there was a press release from the study in transplant ineligible patients, which compared bortezomib, melphalan, and prednisone to carfilzomib, melphalan, and prednisone. And in that study, there wasn't a difference in outcomes. So we can't assume that we know what the results will be. Additional data about KRD were presented at this past year's ASH meeting from the French group. They did KRD as an induction, then they did transplant, and then they did KRD as a consolidation. And they found overall, you can see 57% of patients had a stringent complete response, and a large proportion of patients were also MRD negative, both by flow as well as by next generation sequencing, which again suggests that maybe KRD will be very attractive. And the more therapy that you got, as you can imagine, the better was the quality of the response. The main issues were that there were some cardiac events, and this is something that is a pattern with Carfilzomib. The rates are low, but they are there, and this is something which we're studying in more detail to try to understand whether some patients have a higher risk than others. And cardiac and pulmonary toxicity is broken out here. You can see that there were a small number of events of cardiac failure, pulmonary embolism, and cardiac arrhythmias, which is certainly something to watch for. One of the interesting things from the SWOG study I mentioned earlier, and you could probably show these curves from any trial, is that the quality of the response led to a better outcome. Meaning if you had a VGPR or greater, you had a better progression-free and overall survival than if you had a PR or than if you had stable disease. And so that raises the question of whether some kind of response-adapted therapy may be the best way to go. And there was one study presented at ASH, which was the MRC11 trial, that was kind of interesting. What they did is, you can see they randomized patients to get either cyclophosphamide, thalidomide, and dex, or cyclophosphamide with lenalidomide and dex. If patients got a VGPR or CR, they went on to transplant. But if they got a PR or MR, or stable or progressive disease, they could get randomized to either no further therapy or to addition of bortezomib with cyclophosphamide and dexamethasone. If you look at the here column that says after CVD induction, you can see that those patients who got Cybor-D after the IMiD regimen had almost a 40% improvement in the quality of their response, and this was maintained after stem cell transplant. And when you look at the long-term outcomes, you can see that progression-free survival was much better if you got the Cybor-D than if you did not, although overall survival was not yet different, but that's not unusual in these transplant-related studies where it can take a little bit more time to go ahead and see a difference. But you can see in the subgroup analysis that if you got Cybor-D added, virtually every group of patients did better, suggesting that maybe what you need to plan on is 4 cycles of induction. If you have a great response, keep going to transplant. But if your response is sort of then maybe you need to add a different combination with additional novel drugs. And here again are the transplant eligible data that show good outcomes. And as you can imagine, the toxicity of adding the Cybor-D was mostly in the thrombocytopenia and neutropenia category. Now, I also was asked to look at 2, 3, or 4 drugs, and right now there aren't that many studies really that looked at 4 drugs as induction. One of them was this evolution study from Shaji Kumar, which was a relatively small study, so I think it's tough to make too many conclusions, but they randomized patients to get either bortezomib, len and dex, Cybor-D, at 2 different doses of cyclophosphamide, or the 4-drug combo of bortezomib, len, cyclophosphamide, and dexamethasone. These are the progression-free survival data, and actually it looked like the bortezomib, len, and dex, which is the top curve, did a little bit better, although this was not statistically significant. And these were the overall survival data, but in both of these, the 4-drug combination did not do better, whereas, again, if you look at the response rates here, the VDCR in the middle had a trend towards maybe no difference in response rate, and yet the toxicity was greater. So you're not really benefiting there. And then this study, although it wasn't for transplant-eligible patients, but it's one of the few other trials that looks at 4 drugs versus 3 drugs, Even there, it wasn't straight up because this was Antonio Palumbo's study where he did VMP versus VMPT, and the VMPT patients got VT afterwards, whereas the VMP people did not. And if you look at 54 weeks of induction, you do see a small difference in outcome, but if you're thinking about 4 cycles of induction therapy, it doesn't look like 4 cycles of 4 drugs is going to be better than 4 cycles of 3 drugs. Other options, Jayton Shaw from our center has done a study with RVD and panabinostat, which showed a nice overall response rate. And after only 4 cycles, half of patients were MRD negative. So we're going to hopefully publish these data soon. And then through SWOG, we did a study for high-risk patients where we did RVD versus RVD plus elotuzumab. So far, the only thing we've been able to publish are toxicity data, but hopefully at this year's ASH, we'll be able to show some of the efficacy data. So I think the conclusions that I would leave you with are 2 drug combinations can be used in some cases. I think if you have an older patient or a patient with lots of comorbidity, or if cost is an issue or drug access, I think it's fine to do something like Len-Dex or Bortezomib-Dex. But in general, 3 drug regimens are the current standard of care. And that could be a PI with an IMiD and a steroid, or a PI with an anthracycline or alkylating agent as a steroid. And adding a 4th drug right now, we really don't have enough data to really support doing that. I think the future challenges are we're going to start seeing data with an antibody, an IMiD, and a steroid induction. And it'll be interesting to see whether those are better, the same, or worse than a proteasome inhibitor, IMiD, and a steroid. And especially I mentioned earlier that an oral proteasome inhibitor could be cheaper, so maybe that would win out. The other problem with 4 drug regimens is the cost. Given that the added cost is going to be much greater, I think the benefit will have to be substantially greater, not just like a 20% improvement. I think we really need a huge improvement to justify giving 4 drugs, although antibodies seem to be the best option because they add relatively less toxicity than, for example, an alkylating agent. And then the other question is, if we do 4 drugs, should we give 4 drugs up front? Or should we do, as I showed you, a treatment or risk-adapted approach? For example, maybe high-risk patients should get 4 drugs and standard risk patients should get 3 drugs. Or maybe you should do 3 drugs for 4 cycles, and if you don't have a good response, then you add the 4th drug. And these are things that hopefully we can all work together to try to answer, because although patients are doing a lot better, there are still many folks dying from myeloma, and hopefully we can do better than that. So thanks very much, and hopefully we have a couple of moments to answer questions if